I don't know what a good death is. I don't know what an entity, a non-alive entity, is experiencing. And I'm not sure I've met anybody who could convince me that they did. But I know a bit about dying because for many years I have hung out with people who were in the midst of doing it. And they've taught me a lot about that time, that stage of life that we call dying.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
Picture a hospital room late at night, the soft hum of machines in the background. A family gathers quietly around their loved ones, unsure how to navigate the complexities of end-of-life care. It is a scene playing out every day across the country, highlighting a crucial yet often neglected part of the healthcare, the way we care for people as their lives near an end. Joining me today is Ira Byock, a renowned physician, author, and passionate advocate for palliative care, whose groundbreaking work has transformed how we think about living and dying well. As the founder and chief medical officer of the Institute for Human Caring at Providence St. Joseph Health, Ira has dedicated his career to ensure that end-of-life care is compassionate, comprehensive, and patient-centered. From developing the influential Misola demonstration project to leading the Robert Wood Johnson Foundation's initiatives on end-of-life care, Ira's pioneering efforts have touched millions of lives. Drawing deeply from his early experiences in rural family medicine, Ira witnessed firsthand the profound gaps in care for dying patients, sparking a lifelong mission to humanize healthcare. His belief that moments of crisis can be opportunities for growth and well-being and reshape our understanding of what it means to care for the whole person. In this episode, we explore Ira's remarkable journey from a young physician confronting ethical dilemmas to a visionary leader reshaping the landscape of hospice and palliative care. We'll discuss the challenges of balancing compassionate care with a profit-driven healthcare system, the transformative power of treating patients as whole people, and Ira's innovative visions for a more humane and effective healthcare future. And here is our conversation. Welcome, Ira. Thanks for joining me today.
It's a pleasure to be with you.
I'm so looking forward to this conversation, and we have so much to talk about. And I always like to start with a little bit about your journey. What took you to where you are today? Like, who influenced you? Why this work that you're doing?
Oh, boy. So I began my medical career thinking I was going to be a rural family doctor. I was convinced of that. I wanted to do cradle-to-grave family practice. And I ended up choosing what was the most arduous family practice residency that I had seen, and I looked at quite a few, and that was in Fresno, California. It was actually a UCSF residency. My diploma says UCSF on it, but I spent 3 years in Fresno learning very rural family medicine. So I did a lot of extra emergency department work, surgical work, orthopedics, fracture management, neonatal stuff, OB, all of that. And during my residency, I noticed that there was a strange kind of lapse or a lacuna in how we cared for dying people. As soon as somebody was acknowledged to be dying, somehow they got less of our time and attention. At that time, they quite literally were moved down the hall in the hospital, ostensibly for their privacy, but it kind of also to shield us from having to walk by them all the time and feel like we had failed them. What influenced me was a few experiences. First, I had a crisis of conscience one day when I was on my surgical rotation, and I was asked to, after rounds, to discharge Mr. Waters from the hospital home I said, well, what am I supposed to do with him? Because he had a dehisced wound and we were packing and unpacking this open wound in his abdomen, which was soiled constantly. And I said, what am I supposed to do with him? And the resident supervising me said, I don't know, send him to Surgery C clinic in a couple of weeks. So I sat down and tried to do this discharge because I had to do the discharge and then get to surgery clinic. And Christine, I literally had a crisis of conscience. I didn't know what to do with this man. I couldn't get him out of the hospital. He had too many needs, and his wife had too many needs. They lived in a trailer, for heaven's sakes. Um, and after a while, I realized there was this private Catholic hospital in town, St. Agnes Hospital, and they had a fledgling hospice program. This is 1978 or 1979. I think it was fall of 1978, if I had to guess. And I called them up, and they said, yes, we'll take the case, and came over and met him and his wife and got him discharged home with a lot of help from their team. They also came over to meet me because this was the first time anyone had ever discharged a patient or called them to take a patient from Valley Medical Center, the county hospital in Fresno. And they wanted to sort of kind of congratulate me on thinking of them, but also kind of wanted to make sure I didn't do it very often, right? Because we could have swamped them. And the nurse CEO was a woman named Sally Madrano, said, if you want to start something here, I'll help you. And I was an intern or first year resident at the time, and I was swamped, of course. But I kept seeing patients who needed that sort of help and were having bad things happen because of its lack. I saw patients wait in the emergency department 3 to 4 to 5 hours for their Tylenol with codeine, which was what we were using for pain those days, to get refilled because they didn't even know who their doctor was. And I could look on the bottle of their empty bottle of Ty 3s, as we called them, and see that the person who had written it was one of my residency colleagues who was now doing pediatrics or OB or something. And things of that nature. I remember admitting somebody for a rule-out bowel obstruction who, if you took a history in Spanish, had simply been constipated for 2 weeks because of their opioid analgesia. And that could have been prevented. And it goes on and on. So I and a social work student developed this very fledgling hospice program where we just asked people for an hour of their time once a week, a med-surg nurse, a county health nurse, an oncology attending who was befriending me, a social worker, a chaplain from the hospital, to meet Tuesday mornings at 7 a.m. and run through a file box of patients who had been discharged the week before, acknowledged to be dying. And I got to tell you, not only did we keep people out of the emergency department because we were able to get the resident who filled the prescription the first time to fill it again, and have county health nurses be able to find people once they had changed from one family member's house to another in this vast Central Valley. But occasionally we'd hear from a family that, after mom died, we realized that this last month was the best month we'd ever had together. Or I remember meeting a man in the hospital named Mr. Rodriguez, and I came to see him one morning on rounds, and I said, Mr. Rodriguez, how are you doing today? And he looked me straight in the face and said, I'm well, doctor, how are you? And I got to tell you, I kind of leaned back because Mr. Rodriguez had advanced cancer. He knew he was dying. I had to talk with him myself. And yet he looked me straight in the face and said, I'm well, doctor, how are you? So I realized that the universe was trying to teach me something that medical school hadn't prepared me for and my residency wasn't going to teach me. And I learned, and I'll end with this. I learned that there was the human potential for well-being in the midst of someone's dying. It might not happen to everybody, certainly not. There were plenty of opportunities to suffer terribly because of advanced illness, but that it wasn't only about suffering or its avoidance, that for some people, there was a potential for something positive to happen in addition to the tragedy. There was the potential for well-being. And as a young family doctor who was steeped in human development and family systems theories and all that, this was something, you know, important. And that changed my life. That changed my career.
I think I mentioned to you earlier that I look at death so differently after experiencing death. Not me, I've experienced losing a loved one. And I think sometimes we think about healthcare, we just think about how to stay healthy, how to stay alive, but not thinking about death as part of the whole journey of life. And I think getting more educated about that part, it make a person have a healthier well-being, I think.
I agree with you. I want to distinguish in this education. I make a distinction between dying and death. Dying is a part of living. It is an unwanted, often very hard part of living, but it's a part of human life. Death is beyond life. Death for me is a lifeless state, and I always think that phrase "good death" disserves us because it conflates or confuses dying with death. I don't know what a good death is. I don't know what a non-alive entity is experiencing, and I'm not sure I've met anybody who could convince me that they did, but I know a bit about dying because for many years I have hung out with people who were in the midst of doing it. And they've taught me a lot about that time, that stage of life that we call dying.
How, you have multiple books around this topic, the dying well, and then also the best care possible. And how understanding this process can help us improve the healthcare in this country.
So it's dramatically needed. I mean, you've asked the perfect question. I like to say that although the field of hospice and palliative care may lack that technological sizzle of your other guests, of genomics or immunotherapies or bioengineering or transplantation or functional PET scans, hospice and palliative care really and truly stands as one of the great healthcare innovations and advances of the 20th century. And frankly, what we learned was that the problem-based model of healthcare is insufficient for us to give the best care we can, that the problem-based model kind of transactualizes healthcare, right? And it happened with Larry Weed's problem-oriented medical record, which was a great transformation, by the way, but made us think about new patients through their problem list and not see them as whole persons. I think the innovation of hospice and palliative care is, the old saying that we were given 2 ears and 1 mouth and a butt to sit on. We should sit on it and use our ears more than our mouths. That we learned to listen to people and see them as whole persons, recognizing that they have not just bodies and a set of diagnoses and medical needs, which they do, no question, but they also have persons in their life that are part of who they are. They have an inner life. They have aspirations, which are now, because of their illness, under attack. They have a sense of meaning in their life, which may also be under attack because they can't do the things that have given their life meaning. But that human beings are far more complex and also have far more opportunity to continue to develop through these difficult times than modern medicine is able to see, or has been able to see, without the innovation of hospice and palliative medicine. So I've learned a lot. As a family doctor, I was thankfully equipped with developmental theory, with Maslow and Erickson and Piaget, and I learned in my pediatric childhood development that human development usually is sparked by crises. The toddler who gets a little older and has to go to a preschool for the first time is in a panic and is having a crisis, and his mom goes back to the car and has a good cry after dropping her son or daughter off. And within a few days, that child gets in trouble because he hears, "Johnny, that's not cute." But that mischief was cute just a few days ago. He learns that who he is now is not who he was before preschool. And that different strategies or ways of interacting with others, ways of understanding himself, are important if he's going to be well within himself and with his world. The same thing happens when the adolescent, has a hormonal rage and discovers sex. It happens when the high schooler goes to college and moves away. It happens during midlife when your job gets downsized and you find out that the amount of beer you've been drinking every day now qualifies you as having an alcohol problem, and your spouse leaves you, and all of that. Those crises, when they're survived, spark remarkable development of the human being. What I have learned and what I've written about is that human development is a lifelong process, and that serious illness, knowing that one's time, that one's life is limited, becomes that developmental crisis which can help us complete our lives, decide what really has been important, take a look at what's left unsaid between ourselves and people we love or once loved, reconcile previously strained relationships. I can go on, but that there's far more to this time of life than treating pain and remembering the bowels. But I always tell students, remember the bowels.
Bowels is very important. We don't like to think about it, but it's very important.
Yes.
You mentioned that the palliative and hospice is one of the innovation that's very transformative innovation in healthcare. At the same time, a lot of the healthcare now, I think you mentioned earlier that you see the doctor, 5 minutes in, you're out. And because, again, the doctors are pressured, they have to see as many patients. And healthcare costs a fortune. Everybody needs to, be sustainable in a way. And how do you balance that to treat that person as a whole person?
Well, the American healthcare system is working against you at every point. It's important that we have a context here. Spending time with people does not increase the total cost of care over their lifetime, right? It actually probably decreases it. If you look at natural experiments in healthcare, one of which is called Sweden, another which is called, Holland, even Canada, spends far, far less per capita on healthcare costs over a person's life than the American experience, than the United States does, and yet their outcomes are better than ours. So we really need to just acknowledge that our system is maximizing profits through transactional exchanges with people, billable exchanges, but it's not taking care of people as whole persons well. It's not designed for what I would call human caring and real doctoring. So unfortunately, we have to create workarounds or safe havens where we can spend the time with people. And frankly, I think hospice and palliative care, two parts of the field, two different disciplines within the field, in some sense are safe havens where you have a bit more time to listen to people, to hear and learn who they are as a person within the context of a family and a household and a community and a life story. And doing so, and here's the real irony, doing so actually saves the system money. Both sides of the field, both hospice and palliative care, have been repeatedly shown to save Medicare, particularly where we have all the data, money in the last 6 months or year of a person's life. Isn't that ironic?
So you know very well how that works, and it really saved the system money and save life. I'm not save lives, like for improving quality of life. Learning from that environment, what now let's dream. Like what kind of potential solution that we can explore for the non-palliative and hospice?
Well, pretty easy. We know what works. If you sit with a healthcare economist for, over drinks or dinner have a conversation, I haven't met one yet that won't tell you that universal healthcare would improve value, would improve quality of, the quadruple aim: quality of care, quality of patient experience, diminish per capita healthcare costs, and improve job satisfaction for clinicians, right? Lucian Leap called it joy at work. That's not getting talked about very much anymore, right? What American healthcare is superb at is technical innovations, cutting-edge therapies, the genomics, the immunotherapies. I've been a benefit of some of that stuff myself. I've had some really fancy scans and surgeries for chronic allergic sinusitis, right? Wouldn't have been available 10 years ago. Isn't available in most places in the world, but has helped me a lot. That's where the genius of American healthcare is unsurpassed. But in caring for whole persons over the course of their lives and fostering well-being during difficult times of life, particularly my own focus of the sort of the waning years, months, weeks, days of life, that sort of transactional model simply doesn't work well.
Mm-hmm. But I'm just going to be the devil's advocate. I'm very much thinking that universal healthcare is in favor of it. I mean, I was living in the Netherlands and enjoyed using it. I thought healthcare was easy when I was living in the Netherlands. But the people always say, well, I mean, if you do the universal healthcare, you won't get the innovation because there's no profit to be made. So therefore, we are in the world of capitalism. That's what drives people to innovate, which I don't necessarily agree, because I think usually people who innovate because they really like to innovate.
I think there's room for both. I think that's a weak criticism and worry. I'm sorry, I just do. We're spending 19% of our gross domestic product on healthcare. That's not good for the economy. It's not good for anybody, right? We still have 8 million or 10 million Americans who have no health insurance, and so many who are underinsured, and people experiencing medical bankruptcies in the millions. This is this is silly. What we're doing is silly. And the only reason we're doing it is because of greed. Don Berwick's January 2023 editorial in JAMA is perfect. Salve lucrum, hail profit, right? That's what's going on. And because in a political democracy, with lobbying, changes in the current healthcare system will have winners and losers, but the losers can always throw a wrench into the political machinery. And that's what's happened over the years. I'm old enough to see it happen during the, Bill and Hillary uh, presidency. It's happened repeatedly over the time. I remember when I was at Dartmouth leading the palliative care program there, but also on the board of governors of the Dartmouth Health System during Romney Care, which was, Republican Mitt Romney's step toward value-based care. So it's not universal health care, but at least it was beginning to align expenses with real measurable value, right? And that became Obamacare because of conservative pressure to do it. And then it became politicized because it had Obama's name on it. And everything stalled and we're back to hail profit. I'm not trying to bum out our listeners. I'm just trying to be honest that we know what the best care looks like. We know what real doctoring looks like and feels like. We are challenged in delivering it because of a profit-based healthcare system.
Mm-hmm. I think I read it somewhere but soon that the cost of drugs, I think, is going to exceed the cost of the care of delivering the care.
I don't see how it could be otherwise. In a sense, if each of these new medications costs thousands and thousands of dollars a year, and I'm all for it. What I'm kind of calling attention to is that if we had a system that really valued using innovation in a way that was good for human beings, we would figure out how to incentivize the drug companies and their research and development needs and the bioengineers and the super specialists, the transplant specialists and all of that in ways that provided them with plenty of financial incentive without pauperizing the rest of us or devastating public health and population-based healthcare.
Yeah. I think I was having a conversation recently about how everybody now really upset with healthcare companies because of the profit. And I think the challenge is also everybody has a little share of blame, but we always like to point fingers at other people that the problem is the other side.
Well, I guess I have blame that I've been well compensated during my career as a physician. Thank you very much. But I do think, and we should probably talk about this, that this brilliant field that I was helped to found of hospice and palliative care in the United States is now being devastated by profit and greed coming from the publicly traded and the private equity firms that now are buying up hospice and palliative care programs. And, I can't deny that they have more culpability than a well-compensated palliative care physician. So, I mean, we should just be honest. And I don't think that they're bad people. right? The private equity firms, for instance. It's not that they're immoral, it's that they're amoral. It's just it's not relevant to them. They would look at me and if I said that they were part of a problem, they'd say, "Why are you picking on us? We just eh, they're just holdings. They're not anything. We're not trying to give bad care. We want our companies to give good care, but they're just holdings. We're just looking for some return on our investment within 3 to 5 years." They're so distanced from the bedside, from that office encounter, you know.
Somebody was to tell me that any any organization is like money is needed, important. Without money, you'll die. It's just like blood. You have without the blood, you die. Do you have too much blood? You can die too. And I guess my question: why do you see the industry, the hospice and palliative care, private equity went in? What drove them to go in there
Very
to the
easy.
first
Stable
place?
Medicare and Medicaid funding. That hospice is funded under a per diem, right? For as long as the person lives. You're supposed to be an average of 6 months or so, right? But for long stay patients, they make, $220 a day, whether the patient is visited on any given day or not, whatever the costs are or not, right? It's similar, a little less, but similar under Medicaid or Medi-Cal in California. That's a wonderful target for profiteering. And I wouldn't, I mean, I want those firms to succeed, Christine. I just want them to succeed by having to compete on quality, by giving really good care. The fact is that there are now good studies that show that the publicly traded hospice companies and the private equity firms that hold hospice companies perform less well than the community nonprofits in terms of people getting the services they need, getting the visits, being seen by a doctor, having bereavement support for their families, use of kind of intensive hospice care called general inpatient hospice care or continuous home care, another type of intensive hospice category under Medicare. All of those things, they demonstrably perform less well than. And I can tell you, because I've been in the field a lot and talked to a lot of people, that part of the reason that they perform that way is that they've cut staff, that the caseloads for nurses are substantially higher, that there are far fewer doctors in hospice programs, that doctors aren't making home visits like they were when hospice was designed. The one parameter that the for-profits perform better at year over year is financial margin, right? MedPAC said that in its last report to Congress, MedPAC said that nonprofits on average had a annual margin of 5.8%, for-profits 21%.
But if this, with the world of capitalism, and if the quality is declining, consumers know, well, that is not that quality. Then don't you think eventually things kind of fix itself?
So that should be the solution. You've put your finger on the solution. But the system is rigged.
In what way?
Because your health plan or your insurer determines where you go, what hospice or palliative care provider you have access to in their networks, right? And there are deals made for volume discounts and referral patterns between corporations. In fact, I've been railing against one thing that finally a national organization acknowledged is right, and that is there's been this urban legend that discharge planners in hospitals couldn't provide patients or families with a preferred provider list for hospice care. There's been this urban legend that there's a Medicare regulation that disallows a discharge planner from, let's say UCSF or Moffitt or something, to say, here are the 3 hospice programs in the area that we think are really good. We suggest you use one of those. Um, I know where it comes from. There is a regulation that says that hospitals can't do that with home health companies and with nursing homes. But that regulation specifically excludes hospice providers. So think about what that's done is, free markets might work if the market is free to work, but not if it's not.
Even with that hospital providing recommendation, if the hospice is not in your network, you might not be able to
So
go.
So don't you think that Milton Friedman would complain about that? That 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 defeats the market's ability to drive quality, drive value, you know? So here's my plan. Here's what I've been trying to do, and I've been writing about this recently. I do think that what we need to do is drive competition toward quality. And we need to be measuring things and making information available in the structure, process, and outcomes of healthcare in ways that are valuable to the accountability community, to the Joint Commission, and to other certifying agencies, and to CMS and the Office of the Inspector General and all of that realm, but also to the consumers of healthcare, to patients and families, to the discharge planners and referring physicians, as well as to the health plans and the insurance companies, and let them see what the associations are with the comparative evaluations and value among the different providers, including in hospice and palliative care realms of caring. And we need to do so in a way that is not only transparent, but where the government and the insurance companies actually promote quality data and those quality indices, and perhaps improve star ratings to the patients and families and to the referring physicians, right? That would go a long way. And then I would say one other thing, and that brings us back to the very beginning of our conversation, is that I think as a field, hospice and palliative medicine, we're not going to fix all of American healthcare, but we should start acknowledging and distinguishing ourselves not just as symptomatologists, but as a field that quite intentionally promotes well-being through the last days of life. And we do. I mean, I can think of so many teams I've been part of that intentionally helped somebody get to their daughter's wedding or their grandchild's quinceanera or a grandson's graduation, right? We help people to determine what would be left unsaid between them and somebody they love, to perhaps look at reconciling a previously frayed relationships, perhaps between your wife who you haven't your former wife who you were married to for 20 years before a bitter divorce. Now that you're facing life's end, it may matter to get back in touch, right? Those sorts of things, I'm not saying, I know primary care docs sometimes do that. Oncology teams sometimes help somebody to get to a wedding or that quinceanera. But hospice and palliative care, we do this by intention. It's categorically part of what we do. And I think if we're going to drive competition based on quality, well, we ought to own that and let people know it's not just about their pain in the bowels. We do that really well. But we'll also help you, live as fully as possible and do and feel the things that matter most during this inherently difficult but normal time of human life.
Can I ask you one last question? As you mentioned, that's beautiful. You said how rewarding being a palliative care in the palliative care field, I think. Going back to just like what you said earlier about the private equity and not-for-profit still like haunt me a little bit, is that there's not a perfect system, but the hospice and palliative care facility that is run by private equity that like has a high margin, profitable, they can be profitable. But then as long as there's more not-for-profit, you're saying that they are, they're still around, they provide quality care, people keep going on to them. Will that be okay eventually?
Private equity and publicly traded companies are swallowing up nonprofit hospice companies literally in the hundreds per year. The system is not, the market is not on a level playing field.
Right. Is it because the not-for-profit, if they don't take the money, they belly it up? Or is it because they got tired and they also want to cash out?
Oh, you're such an MBA business person. No, it's because they're staffing their programs well. It's because their nurses are seeing 12 to 14 patients at any given time, not 18 to 22. It's because they have doctors who actually are involved in care, and doctors are expensive. It really, if the for-profits and their holding companies are requiring hospices to return margins of 18 to 22% per year, staffing and services will be curtailed.
Right. But if you're not for profit, as long as you get the 3% margin, you're okay.
That's tough. Yeah, I'd say 5% you're okay. Yes. But it's hard to compete in those markets. And it's hard, it's the United Healthcares and the Aetnas and of the world, the Cignas of the world, really don't support that level of staffing and a range of services that that hospice is intended to provide. This isn't it is my opinion, but I can back up this opinion with MedPAC and published health data. I mean, it is what it is. And it's not like, oh, well, this just is an association. No, this is by design. It's their business model. So sorry. I think the only way to move this is to shift the ground under which they're sitting and move from a finance-based competition system to a quality-based competition system. I want them to thrive, but I want them to thrive by succeeding in all four quadrants of the quadruple aim, including the well-being of my clinical colleagues.
Okay. I know we are short on time, and I want to ask one last question for any innovators who are interested in doing something to improve or in the space of palliative and hospice. What are the areas that you think that is very much needed besides fighting the private equity?
Well, yeah, I wish that wasn't what was needed right now. I think the field in the realm of its research is quite healthy, and I'm excited by what I see. I was just reviewing an agenda of an upcoming symposium, national symposium, and it's just exhilarating to see all the research that's being done in both symptom management, in health service delivery models, and meeting the needs of people with particularly complex syndromes. All of that is fabulous. I think we need continued innovation and development in measures, in metrics, particularly in converting subjective experience to objective metrics that can then be monitored and tracked and compared qualitatively or quantitatively, really, between programs. I think we need continued work in the therapeutic interventions to help people through these, for me, I would term difficult developmental crises. I think in general that your listeners, I would hope that they would realize that innovation does not always require artificial intelligence, data technology, genomics, that sometimes the rich complexity of human caring offers opportunities for innovation that others have missed.
Mm-hmm. Well, with that, I'd like to thank you for your time and sharing your insight.
It's been a pleasure.
And your thought on this space.
I hope what our conversation is of value to others. It's been of value to me, Christine. Thank you again for asking me to be a guest on your show.
Thank you. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Minato, and thank you for listening.